combined work group meeting of the performance work group and the payment work group. We appreciate your flexibility with your schedule. We erred on the side of caution in the last minute, and I apologize for the late notice, but I think the icing conditions were quite dangerous in the morning. So let's go around, introduce ourselves, and we have a few number of members who are on the webinar. And please also tell us which work group you are representing. Thank you. This is Shuli Chalakola, by the way.
Allison Schuster, Performance Measurement Work Group.
Stu Gutterman, Payment Models Work Group.
Bob Murray, representing Care First, and I'm on both.
John Hamper, Care First, Payment Models.
James McGee, Payment Models.
Dan Cochran, Shady Grove Adventist Hospital on the performance model.
Kristen Polio, Adventist Healthcare on the payment model work group.
Barbara F.T., LifeBridge Health Performance.
Paul Parker, Maryland Healthcare Commission, payment model.
Barbara Brocato, payment models.
Ed Baranek, Johns Hopkins Health System, Performance Measurement Work Group.
Justin Dybel, Mercy Health Services, Performance Measurement Work Group.
Tracy Laval from the Maryland Hospital Association on the Performance Measurement Work Group.
Brett McCone from the Maryland Hospital Association, and I'm subbing for Mike Robbins on the Payment Models Work Group.
Teresa Lee, Maryland Healthcare Commission, Performance Work Group.
Andy Woodham, Payment Models.
I'm Jerry Smith from HSCRC, and I'm on the Payment Work Group.
Thank you. And who we have on the phone?
Ann Meck from the Payment Models Work Group.
Donna Kinzer, Payment Models Work Group.
Mary Jo Braid Forbes, Payment Models.
Raymond Gray, Payment Models Work Group.
Ray, was that you?
That was me.
Okay, it's better now. Thanks.
Okay, and Michelle Mann, I think I'm able to come in now.
Okay.
Thank you.
Thanks. Okay. So what we thought we'll do, given the change in schedules, is we'll go quickly on the items that we have more time. The two items that we will spend most of our time is on the aggregate amount at risk for quality programs and the readmission scaling. The staff is still planning to have final recommendations to the Commission next week, unless things change after this meeting. So we are going to go through the agenda items 1 through 3, or actually 4 as well quickly. Since David is not in the room and he has the second agenda item, let me start with the market shift and then move from there. Donna, before we start, do you have any comments?
No, I think I'll just move right on ahead.
Okay, good. So you had a PowerPoint presentation on the market shift adjustment update. We presented the draft principles to the Commission in on February meeting, excuse me, and we received, in general, a positive feedback from the commissioners. Our algorithm, I think that the way we are measuring has been, in general, accepted positively. So I'm going to go to the slide number 5, where we are with the work in progress. We just released the 2015 Q1 and Q2 data last Friday, and given the trends what we are looking at, we expect some data revisions, especially outpatient data is requiring a lot of examination and revisions. And looking at the changes and the service line trends, we are trying to understand the implications of the market share adjustments. Outpatient weights, we still have work to do in understanding how the grouping works and the calculations impact different hospitals and the cases. On the outpatient, we had separated oncology, drugs, and radiation therapy from the general outpatient services because of the recurring visits. Our plan is to look more patient-level analyses to see if we can calculate a similar market shift to the methodology. From now on, we are focusing more on the cost side since we feel comfortable with the way we are defining and measuring market shift. Now the question is, what is the value of those market shifts? And then we've been looking at a standard one price, state average or some sort, or a hospital-specific cost calculations. In addition to the cost, the other issue that we are working on is the approach to a payer, or what I define market share organization, some entity that can move the patients ahead of time. So how do we deal with them prospectively? What policies we need to have in place so that the payer strategies are not discouraged with the market share calculations. In terms of implementation timelines, our plan is to have the first adjustments done in the 2016 GBRs using a 6-month data. This will be comparing July to December 2014 discharges to July to December 2013 discharges. And after that calculation, we are going to go to a 12-month period with adjustments done again in July rate update. So I'm going to walk through some of the tables you have, but is there any questions so far on the work in progress on the market share? Hearing none, let me just walk through the tables that you have in front of you. So the table 1 is the fiscal year 15 quarter 1 and preliminary quarter 2 market shift analyses, and the table is sorted by the ECMAT growth. We've been using these tables both for the analysis purposes, but also understanding the changes by hospital or by service line. And as you see, at the grand total level, the market shift calculations are equal to 0. With the algorithm, the only increases that we are giving are based on the declines in other hospitals. As I said, still I think this data is preliminary, and I would take caution on the numbers. The second one is a similar table. Table 2 is the service line specific calculations. Again, the market shift would be equal to 0, but then you could see the highest increases that we see are on infectious diseases, orthopedic surgery, and obstetrics. And down below you see the radiology, lab, and drugs that decline the most. Again, the outpatient services, we think there might be issues with the way we define the outpatient drugs and the lab, so we are still working through those issues as well. And the last table is looking at what the market shift calculations are by service line, and I would like to thank Kim about printing these in a large sheet so everyone can read it much better than my tables. So on this one, what we did is we looked at the services, so we calculated the ECMATs for the base year, 2014, so this is 6-month data. And then looking at positive adjustments for each service lines. So for orthopedic surgery, there's about 40,000 ECMATs in our base year. And then through the algorithm, the adjustment is 1,490 ECMATs. So it's equal to 3.7% of the service line for the state. And you see 24 hospitals have gains in total, and then 22 have losses in total. So looking at this trend, you see that the shifts are kind of happening equally between the hospitals, and the surgical service lines seem to have the highest shifts if you use the number of ECMAs as a benchmark.
I'm going to ask a really basic question. So these shifts just go one hospital to another, not, procedures that were done in a hospital moving to outpatient.
That's correct. So the way that we are calculating right now is looking at the hospital-to-hospital movement. In one of the slides I skipped, there are other shifts that we are going to be looking at, but not through this methodology, shifts to unregulated places, shifts to other states, or patients coming to our state from the neighboring states, and also the even though we are looking at the inpatient and outpatient trends may have some impact on these calculations. So we may need to combine like the PCIs or some of the other lines together.
That would, when the time comes, that would be so instructive to see in one paper, again, the hospital-to-hospital shifts, the outpatient, the other variables.
Right. Yeah, I mean, that, as you know, the source is the other claims that we currently don't have the access to, but with the Medicare claims, being released to us, we had a total cost report. At the aggregate level, we are going to start looking at it, and hopefully we'll go down to service lines at some point. Any other questions?
Well, Shuli, this is Michelle. I was wondering, how does new markets fit into this system? This shift is looking at existing kinds of volumes just moving from one place to another. If you've seen examples of, like I'm thinking regulatory changes, the Medicare expansion, or other things like Cmmi growth, where do those things get captured in the system? Because I don't think this market share is going to pick that up, but they're costs that I think should be considered.
So the you mean the new services that will be provided by the hospitals?
Right.
As an industry, not like if the hospital is not providing one service but opened up a new service, it's going to be picked up by the algorithm. But as an industry, if we have a new cases that we are going to be taking care of, that will be buried under these general service line categories.
Yeah, I think
for a new service, that really what we're focused on is a population-based methodology. So the population growth assigned is supposed to cover new services, and if we have a new service and we get rid of an old service and we have some population growth, then that's really how the model is constructed.
Okay, so, well, I just wanted to understand, because I'm not sure population doesn't take into account just the demographic growth, and then to add to it a service growth to it. That's just something we should all understand.
Yeah, I mean, I think that the whole model is focused on tying the service level to the population. And so if we want to have a new service, then we have to get rid of avoidable utilization so that we can afford the new service. So that's kind of the concept of the model, is to tie the growth in volume to the population.
Okay, so I guess then we need to just give consideration to timing of new volume comes in sometimes faster than PAUs can come out. But okay, just wanted to understand that.
Right, and the consequence of that is then the rates have to go down so that you can stay on budget. So that's kind of how the system overall works. And then we have some specific exceptions for particular services, such as quaternary, some highly specialized quaternary care and the transfers, as you know.
Right.
But right now, the remainder of the services are generally captured under the population model.
Okay, thank you.
And on the CMI, so I didn't go through the calculation of the EC math, but it's a case mix adjusted discharges, and on the outpatient side, they are converted using the charges once we weight the outpatient visits, similar to our case mix adjustment on the inpatient side.
Okay.
All right.
All right, thank
Any
you.
other comments?
Yeah, this is Ray Gray. Are you doing this by zip code, and is it all zip codes, or are you doing it by region? I'm afraid I don't have any of the material you haven't passed out in the room, so I feel like I'm a little bit at a deficit.
Thank you. I did skip that part since we had it in the last. So basically, it's at the zip code level. It includes all Maryland zip codes, and at the service line. So each service has the calculations done for each service separately at the zip code level separately. So that way, we are kind of trying to make sure that the increases and declines are more related to each other. Once you start summing up, the use rate differences between regions have an impact on these calculations. But for the rural areas, we are trying to look for a combined zip code so the number of cell sizes are more manageable for the rural areas.
Good. That would be because changes in number of cases or even revenues in some zip codes with very small volumes could have perhaps an unwanted impact. And the fact that you're looking at combinations makes sense. Similar to what Jerry did with some of the demographic adjustments, he used broader regions when we were last doing the TPR contracts.
Thanks.
Okay, thank you.
Julie, I have one question regarding and you made mention to it earlier about out-of-state, but when we look at out-of-state, and certainly those in the district where we have Maryland residents going out, not so much when we're bringing folks in, but we have Maryland residents going out of the state, and now maybe to a higher percentage we're able to keep some of those people in the state. How will we factor those in? Because that does seem to be a fairly significant, there's some anomalies when you look at the numbers, especially for the hospitals around kind of the border of the state where it's either with the district or other states, where they seem to be going in different ways with market shift and the economic growth, which you would expect it not necessarily keep up, but you wouldn't expect kind of going the other way. How will we get to that level of data from the other states for all payer data?
So it is a challenge, as you know, to get the all-payer data, but since we have the Medicare claims on a more timely basis, we could envision having a similar calculation done, including the at least the DC hospitals for Maryland's residents. And I know the MHCC has moved to a quarterly submission for the private claims. So our intention is to look at those two data sources. We encourage the hospitals, if they have their own resources, also to come forward with their calculations. But to me, once we do these, that they have to be in a different timeline almost. I think, you know, our data comes very quickly, and the APR DRGs are not that difficult to put in. So we, you know, it may be in a different timeline, but we'll try to make those adjustments on a timely basis as well.
And so the all-payer claims database does have Maryland residents in DC hospitals, and then we have the Medicare data that has Maryland residents in DC hospitals. We don't yet have the Medicaid data in an electronic format, but there are those data sources that are available, and also several of the hospitals that have the health systems that have hospitals in both geographies have agreed to provide cross-border movement as part of their global budget agreement. So there, as far as that particular border, there are some resources to help us move along in that effort, but it will be behind in the timeline. There is one further resource that may come into play, which is Chris is in the process of getting ADT data from the DC hospitals. We haven't really assessed the use of that yet.
All right, to be continued, I guess, for the market share. I forgot to mention we had the subgroup meeting last week, so we are going to continue to work through the outpatient weights with the subgroup and digging deep on the data analysis with them. All right, so I guess we will move to agenda item 4 for the Capsule policy discussion, and Jerry will lead on that topic.
Thank you, Shule. We were just going to announce that we are beginning to look at how to provide capital to hospitals now for major CON projects, now that we're under global budget arrangements. By law, we are required to work with the MHCC and comment on the financial feasibility of certain capital projects. Certain capital projects, the hospitals can take a pledge, which means that they would say that they would pledge that they would not need an increase to rates to cover the costs associated with the project. Some CONs do not require us to review certain things. It depends on what it is. But for many of these projects, we are asked to provide some form of recommendation on these. For minor projects, we don't normally provide additional revenue to hospitals. Each hospital has a certain amount included in its rate structure. Right now, overall, it's about 8.8% of the total rate structure is provided to hospitals to cover capital needs. We don't tell hospitals how to spend their updates each year, so it's up to them if they have a project that they think needs to be paid for and put into place in a given year. They can use money from their update to pay for that. Where we do have something, though, is where we do normally work with hospitals is on a major capital projects. And in the past, okay, hospitals did not always need an increase to rates to cover the costs associated with these projects. Many of these projects were paid for through marginal revenues that were generated from the hospitals for growth in volumes. So we were providing hospitals with 85 cents on a dollar for increases in volumes. The marginal revenues generated from those volume increases were paying for these major capital projects. We did have a partial rate application that only looked at capital in the past, and that was for major projects. And that had to, were only for hospitals that needed an increase to its rate structure. Not many hospitals use that avenue, but we believe that might be more now that we've changed things. Under the GBR from now on, hospitals will only be provided an increase for volume change increase, only if it's for market shift, okay? And if it's for market shift, they're only going to be provided 50 cents on a dollar. That's meant to cover the variable costs associated with paying for those additional volumes. And so if there's a major capital project now, we believe that more hospitals will be coming in asking for increases to rates or some adjustments to its capital, its GVR, it's under some mechanism. And so right now we have 2 hospitals that have filed rate applications. Dimensions is one, and the Adventist is another. They've filed major capital projects. In both instances, they're moving their facilities from one location to another. Both of them have requested significant increases in its GBR in order to finance the costs associated with that project. And now we're looking at, in the past, we did have a partial rate application, but that was basically looked at how the hospital was operating on a per-case basis. We're not sure whether that continues to be reasonable under the current GBR structure. So now what we'll be doing is working with hospitals and others to determine what is a more reasonable way of financing major capital projects now for these current projects and then for the future. So in your packet, we put together some of our preliminary thoughts and some of our preliminary principles that we think that should guide us through this process. And one of the first things that, and we put some other thoughts on what we should be addressing, and really we should only be addressing major capital projects. So the first thing we need to do is define what that major project is and what would be associated with a major project. In the past, those projects were ones whose the total cost of the project was at least 50% of the revenue that was being generated by a hospital on a yearly basis. So, I'm sorry. Oh, okay. And some of the other things that we did look at in the past was the hospital's overall rate structure to start with. If the hospital's rates and costs were reasonable, then we felt it was reasonable to provide some additional revenue to a hospital to cover the cost of the project. If the hospital's costs and rates are already high, we may ask them to finance more of that project through its current rate structure. We now believe it's also important to start incorporating quality measures into this process. So to try to ensure that hospitals are providing good quality care to the patients. We also want to ensure that we're not going to do something that will add to excess capacity in the state. We believe under the new system there may be some excess capacity generated, and we don't want to approve a capital project now that would make that situation worse. So these are some of the things that we started looking at. We've started some preliminary discussions with some hospitals and some other some payers and others just to get some initial thoughts on this process and what we should be looking at. As I said, we have 2 CONs right now that we're going to have to provide some comments on in the near future. So we will come back to this group with something a little more detailed in the future, but we just wanted to introduce this at this meeting today. Okay. Any questions? James? James?
Yeah, I'm confused. If a hospital gets a rate increase, and doesn't that affect the total revenue?
Yes, it does.
And then does that come out of other hospital revenue?
It will be included as part of the 3.58. It'll be factored in when we look at what to provide hospitals overall in a given year. Whatever that increase is, that would be factored into that 3.58 and withheld. For instance, this past year, right, Germantown opened, and we withheld 0.4%. Okay, because we knew that was going to finance that was going to be used to finance that project. When we look at our update factor for this year, there's an additional amount that's going to be withheld from that update because of the incremental growth in that project that's expected for this year. So that there won't be any, I mean, that will have to be considered when we look at in the future how what we will be providing hospitals overall. These projects, by the way, the rate increase is not provided to the hospital until the project is completed and the project is open and available to the patients. So these projects that we're currently looking at, their scheduled opening date is probably 3 to 4 years from now. So we will have plenty of time to take into consideration that in future updates when we're providing updates in the future. And we've always done that in the past. We have looked at when we provided hospitals increase for a given capital project, okay, that was considered when we were looking at what else to provide the hospitals at that time in the future. We used to consider as part of what we called slippage, but that term is in the past, so we'll find another term for it. Stu, you had a question?
Yeah, Jerry, so is this, is the increase, when you do give a hospital increase, is that temporary or is it permanent?
No, this is a permanent increase. It's normally associated with additional costs for financing the project. And so if a hospital will come in and they'll have to pay, you know, most of these projects are financed through capital borrowings. And so they're associated with the debt. A lot of it is associated with debt service for these projects in the future. And you know, originally, some time ago, hospitals would come in with these projects and they'd ask for an increase to rates, and we didn't have a way to determine whether they would be provided that increase in the future. We developed this partial rate application for capital where the hospital could come in and only look for a increase to rates in the future for these capital projects. That would allow us then to look at that project knowing in advance what amount would be provided to the hospital at the time the facility would open. It also allowed the purchasers of bonds, potential purchasers of bonds, to look at the projections that were being provided and know that those projections had been reviewed by us and that we believed that those projections were reasonable. Prior to that, hospital may come in and say, we need a $19 million increase to make this capital project work. And until, you know, the MHCC would talk to us and say, is this feasible? And we would say, well, we're not sure whether we're going to provide them with $19 million. So we had to develop that process. That process is still in place, by the way. The only problem is now, though, that many hospitals did not ask for an increase because they were paying for it through these volume increases. Now we believe that we've already got two that have asked for, the two that are active actually are asking for increases. We have a few others that have been submitted. They're on hold, and they're on hold at this time waiting to find out how we're going to deal with these projects in the future. At least I know one is. The other one is looking at how we're going to view capital on a regional basis.
And is there a process to track the impact of those capital investments to see what their impact is on access and quality and cost?
Well, that's one of the things that MHCC does. They look at some of those things, but we're going to take more of those things into consideration today.
Well, that's in advance, but I mean, is there kind of the equivalent of a post-market surveillance mechanism, you know, so that you can see what's actually happening? So, you, I mean, it could also help your decisions in the future.
We are going to be monitoring the quality stuff, okay, in the future. We're going to be looking at that. We're also going to be looking at access in the future too. Paul, do you want to comment on that question?
Well, just to maybe provide a little more detail on what's going on right now. We've got 4 hospital projects that I think might meet our historic definition of a major capital project right now. About $1.4 billion in total. 3 of those are full hospital replacement projects. Washington Adventist, Prince George's Hospital Center, and University of Maryland Shore Hospital at Easton. And then we have a $132 million project proposed by Southern Maryland Hospital Center, MedStar Hospital in Prince George's County. So I think one way of looking at this, if you remember in June, I gave you a lot of information on, you know, kind of capital spending by hospitals. You know, how much is capital spending as a percentage of total expenses? About 7% in 2013. It was the statewide average. We also looked at the nominal amount of spending per admission that capital represents, depreciation and interest on long-term finance. And when you look at these projects, I mean, 3 of them, Prince George's Hospital Center and Washington Adventist, 2 of our 3 replacements, and MedStar Southern Maryland, those are hospitals that you actually, they look pretty good because they're in the bottom quartile in terms of the percentage of their operating expenses that are in capital now. So, you know, just generically, they look like hospitals that have, you know, gotten their capital spending down. They're ready for a major project based on the level of capital spending that's going on. They're also in the bottom quartile in terms of expenses, capital expenses for equivalent inpatient admission. So they're in a sweet spot. The one that's got a problem, and that's the one that actually started a review quite a while ago and then put it on hold, and so we're waiting to hear back from them, is the Easton project. They're not in a sweet spot for doing a replacement project because they have, they're in the top quartile in terms of their capital expenses to total operating expenses ratio, and they're in the 3rd quartile, so they're moderately high in terms of their capital expenditures per equivalent inpatient admission. So that's the one that just the ratios would suggest are a little problematic. The good news is we haven't approved any major capital expenditures for a couple of years, but that's basically because of this process. We have Washington Adventist actually has formally begun. They're docketed finally, everyone had to go through this process of basically getting a global budget agreement in place before they could actually start the review of these projects. So it's really delayed these projects for a little over a year at this point. But Washington Adventist is docketed, and Prince George's will be docketed very soon, so we'll be reviewing those together. Southern Maryland's kind of disappeared for some reason, but they have a global budget agreement. We're expecting them to come back with an amended application. We have been for the last 6 months, actually, but it hasn't happened. And Easton has gone into hibernation for a while, but they're coming back. And when you look at, if you look at the kind of the zero-sum game issue here, you could approve all these projects, and it would have an incremental impact, obviously, within your 3.58% budget cap. As Jerry mentioned, that wouldn't start for a few years, because these are all projects that are going to take a while to implement, and they don't get additional, they wouldn't get increases in their budget cap until the projects are finished. So one of the things you might recall is that, I kind of said in June, you don't fundamentally have to change the way we regulate capital investment, which is generically they come to MHCC. If MHCC finds it's a project that's needed and cost effective, and with consultation with Jerry, we also find it to be a financially feasible and viable project, then that qualifies them to come to HSDRC after they get that certificate of need and ask for an adjustment in rates, or now it's an adjustment in their revenue cap. So we can approve all these projects, and it looks like we've done some rough analysis of what the impact of the spending would be, and it wouldn't cut too much. It wouldn't absorb all the money that's out there within the 5-year limits that you're trying to maintain under the new waiver. One of the things we did suggest is that because we are in a world where these limits exist now, and we never had that historically, we probably want to try to shift CON in the direction of longer-term planning. We actually need to know what the big expenditure projects are going to be over the next 5 years, so we can actually do a better job of looking at, okay, how big a hit is that going to be within the caps we're trying to live under? How much is going to be left for everybody else to deal with inflation and operating costs and other issues? And we're going to start looking at, basically revising our regulation to ask that, or to require that as part of the process, that we get a longer-term perspective on major capital projects.
So one of the main things, though, that we wanted to ensure everyone that is that, whatever is provided to the hospitals in the future for capital would all come under the 3.58 and have to be considered when determining what the total increase for that year would be for all hospitals. And so if we go to the commission and a rate increase is approved for the hospital in the future, that would have to be considered when we're looking at what we would provide in the way of an overall rate increase for all the hospitals in that particular year. And so, as I said, we did this last year with the Germantown Hospital over in Montgomery County, and Washington Adventist, I can tell you, they have requested about a $19 million increase to cover the costs associated with this project, and Dimensions has requested $21 million per year. Okay, and that's to cover the life of the project. So these things will be reviewed, and again, this is just to start the process, and we will be coming back with you. Anyone that would like to speak to us individually, we're all ears. Wait a minute. James?
Yeah, what I've heard so far is we want to because we can. We've heard a lot of discussion around the table here about in order to meet the objectives that hospitals need to invest in quality improvement and care coordination and things like that. And so to what extent are these issues going to be entered into the equation in terms of assessing the viability or the relevance of these capital improvement projects? Are these projects taking away from needed investment in other areas for quality improvement and medical record investment and care coordination and all the kinds of things that we've talked about that are needed to meet our goals and staying under budget?
Right. Yeah, I would think that all these things need to be considered. So the investment in infrastructure and care coordination and all these things, they're extremely important to us, and they probably would have priorities over an increase that might be a hospital would ask for just to replace bricks and mortar. So all these things have to be considered in the future, but the main thing we have to do is ensure that whatever we do, it's in the best interest of the public. It provides the best care. It's going to provide the best care to the public, and that it's needed, okay, for the public good. So, I mean, our concern here is to ensure that the public has access to good quality care and to make sure that that's provided to them at a reasonable price, and that's what we're going to continue to do. Bob, you had a question real fast?
Yeah, I just want to get a sense of timing on this and, you know, how long a process of discussion you anticipate, and then do you anticipate a formal recommendation to the Commission at some point for a change in policy?
Well, we will certainly be presenting something to the Commission at some point, and I would think it would be in the fairly near future because we have these applications that we're going to have to be reviewing, and there's going to have to be some feedback on those in the near future. So I don't think it will be a significant amount of time before we would have to come back to the Commission with a recommendation on what we would do and how we would consider providing additional capital for a hospital as part of a major capital project.
Okay.
Okay. Again, as I said, for these minor projects, for ongoing capital needs, hospitals are expected to finance that through its own, through the money that's currently being provided to them. If they think their overall rate structure is inadequate, that they can file a full rate application and ask us to review all of their costs, at which time we would not only look at capital costs, but also all other operating expenses in addition. And so provide the hospital with reasonable amount for all their costs. And so, again, this is only for major capital projects. And we will be bringing this back to you. Yes, Barbara?
Good question, and I'm looking at David. You know, when you look at these major capital costs, the hospitals are in the governor's capital budget. I mean, that's separate from what we're talking about, I would guess. But what we're looking at, or how that fits with this new administration, and you know, Mr. Neal in particular saying, you know, the state's got to start looking at, you know, its capital costs. If that's reined in, is that going to have any impact here? Is that related or unrelated here?
Well, I'll comment first, okay? The capital costs associated with these projects are normally not part of the state's budget. Okay, they normally. Now, there are certain projects where the hospital has gone to the state, David can tell you about those, where they have specifically asked for money from the state in order to finance a portion of that project, and there are a number of hospitals around the table that got some of that, okay? And that is considered when we're looking at the total cost of this project. So we are talking to hospitals and saying, when it comes to financing these projects, there's going to be other revenue sources that we're going to expect you to tap into, okay, and other things to use when trying to figure out how to finance the total cost of this project. And efficiencies and productivities, you know, state money that has been promised by the state for other philanthropy. There's lots of other ways that hospitals are provided money to provide for these capital projects, and we'll consider all of that in the future.
Yeah, Sherry pretty much covered it. I would just say, I mean, there's occasionally an extraordinary capital project that gets funded in the state capital budget, but that is unusual and not, I can't speak for the new governor, but that's traditionally not been something governors want to commit lots of money to lots of different projects. So the primary funding source would continue to be through
Yeah, and I guess my sense is just the overall feeling is that that'll be less likely in the foreseeable future, those funds on the capital budget.
Yeah, I mean, I think most people realize this. We do have one of those unique projects. The Prince George's Hospital Center replacement has I think $420 million committed from the state and from Prince George's County to support that replacement hospital project. But clearly that is an unusual circumstance. Historically, you've had two hospitals in the state, the two academic medical centers, who've gotten substantial grants here and there that support capital projects. And there's also been historically a state capital investment program for hospitals that's administered by the Hospital Association, but that's generally for fairly modest capital projects that fall below the threshold of CON regulation anyway.
Right, that's $5 million total.
Yeah. So generally, there's not this is not part of the state's capital budget, these projects, and there aren't any state hospitals or public hospitals of any kind in the state of Maryland.
All right, so as we said, we'll come back to you. So this was the preliminary discussion. I appreciate all the comments. So we'll do a quick discussion on the update factor. Again, the timelines on this is April, May. So David is going to walk through the most recent numbers with us, and then we'll move from there.
All right, I think you have a sheet in front of you. I don't know if you have Excel sheet. All right, you have an Excel sheet in front of you with something like this. It's just sort of an update of data you've been presented the last few meetings. You should ignore the very top part of that. That was supposed to be hidden cells. We're working on updating the kind of maximum allowed growth based on some of the comments that were made at the last payment models work group. So this does not reflect any of that updating, so don't focus in too much on that. Did want to highlight a couple of changes, though, in the lower part of the chart, the components of the revenue change. First, the inflation has remained the same. We haven't had any new updates from Global Insights, so about 2.4% is the inflation level we're using. The adjustment for volume remains to 0.57%, which is the state planning estimate of growth in population. Within that, a small amount of that will be used to cover categorical inflation for things like transplants, very specialized hospital services. Our transfer policy, which we're estimating would cost somewhere between $1 million and $5 million in fiscal 16, and market shift adjustments, which we think roughly could be a $4 million cost. So those are relatively small dollars out of that 0.57%. The infrastructure allowance, we've continued to leave that blank for now. That's an item that's going to have to be a discussion probably at a future meeting. Kind of piggybacking on the capital discussion you just had, Holy Cross Germantown Hospital opened in October. There was some money included in the fiscal 15 rates, and we've now quantified sort of the annualization amount that will be built into 16, which is a little less than 1/4 of a percentage point. The other adjustments haven't changed. There's set-asides and so forth. At the bottom of the page, you see so before I get to the bottom of the colored highlighted section there, the net increase before we get into uncompensated care and some other adjustments is 3.65% revenue, which would equate to about per capita growth of just over 3%. Then there's some components of the revenue change that are sort of outside of the sort of normal inflation and so forth. One is the uncompensated care. Based on the data that we presented at the last meeting, and adjusting for the Medicaid differential, we're expecting about an 0.8% reduction in uncompensated care. We will be coming back to you at the next meeting with some follow-up on some of the information that was presented last meeting. We've continued to gather some more information, and many of the hospitals are still reviewing the hospital-specific data, and we want to give them a full opportunity to comment on the data and for us to investigate any concerns they have. So this is not a final number, but it's sort of the placeholder based on what we presented at the last meeting. And then the utilization impact of the Medicaid expansion, as we discussed at the prior meeting, there has been an uptick in utilization by the people who are enrolled in the expansion when you compare their total hospital charges post-expansion to the same people's hospital charges pre-expansion. And we're still working with Chris to dig into that data further, particularly trying to understand at a product line level what types of services are these folks using, how much of this was sort of a short-term pent-up demand and it's not going to be an ongoing cost, and how much is likely a reflection of ongoing expenses now that people have insurance. So we'll be presenting information on that at the April meeting. And then just the annualization of the MHIP adjustment that was made in the current fiscal year in October, so it wasn't a full year. So when you take those things into account, you end up with a net revenue growth of 2.6%, per capita growth of about 2%. So there's still some blanks here that need to be filled in and some numbers to be finalized. I'm sure there's quite a bit of further discussion that we'll need to have. We just wanted to give you kind of a quick update on where the numbers are as of today. Any questions, comments? Brett?
Just a couple comments, and I know, of course, you said at the very beginning to ignore the upper right-hand corner. But I guess one of the questions, and I know, we as the Hospital Association raised this the last time, but looking at that on a cumulative basis, so that's something that's still on your radar, because we did see it on the one that came out.
Right. So yeah, we are working on the calculation of a cumulative basis. We're trying to get a firm estimate of the fiscal 15, charges that we expect for the whole year. And we're also trying to gather a little bit of information to give you a sense of where we stand on the Medicare test as well. So we hope to be able to present all of that at the April meeting.
Okay, great. That was because that was the second point I was going to make, is that as we look at this and we've heard comments over the past couple months about the ability to fund things in the system, and one of the concerns is just where we are with respect to the Medicare test. So it's difficult to look at this on an update factor perspective. So I think the sooner we can release that data, then I think the better, to give us good context of what's in the system and what's available.
Agreed.
And what the cumulative results of that are.
What would be the cumulative amount that could, in terms of maximum growth, if you included last year?
Well, we haven't finished the calculations, but because we came in well below the 3.58% in calendar 14, and we're likely to do so in fiscal 15, it could be greater than the 3.58%. But we will present the actual calculation next month.
And then what would be the process? Sorry. And what would be the process for having that discussion of increasing it on a cumulative basis? Like, what would be the justification for going in the process for arguing at a higher rate increase?
Well, we would suggest looking at the factors that are laid out on the page: inflation, volume, some discussion of what's an appropriate infrastructure adjustment. So pretty much the items shown here. And it really needs to, again, be in the context of both tests, both the all-payer test, which we know we're doing well on so far, and then the Medicare test, which we need to present some data on to give people a sense of where we stand. We need to achieve $330 million in savings over the 5 years.
Just to respond to that as well. So I think if we look at the cumulative test, if we're just talking all payer for a second, at the end of the 2 years, the total 2-year growth could be 7.3%, because the allowable growth is 3.58 each year incrementally. So I mean that is the ceiling. We certainly appreciate the historical use of the components here, but I think that would be a general discussion in the context of the update factor, to make that determination with how we've truly changed the system over the last 2 years, and what we need, what makes sense from a system funding perspective in the context of those major changes.
Yeah, and it would be helpful to understand the process of that discussion in terms of how people are going to present going above what's already being on a per capita basis, particularly if all the hospitals are meeting their global budget.
So we didn't say going above. but we understand what the limit is there. We are not above that limit.
Right, but it's going to be beyond what's presented here in terms of what you'd be arguing for.
Well, I think there's a discussion of what's the maximum that we could go up to kind of cumulatively over the multiple years, and we're committed to doing that calculation. And then beyond that, there's a discussion of what's the appropriate update for 16.
Right, and we have to talk about what the system investments are needed in a much different environment than the historical system that we've operated in.
Any other questions? Thanks.
Moving along, so we are now going to switch to the quality section of the agenda items. And I should state that, so we have three quality-related items. The first two are, we would expect, interest everybody. And then lastly, we have the QBR measure detailed discussion. So feel free to leave the meeting once you feel like. It won't be judged against you. So to start with the aggregate amount at risk, so we are going to review the Excel spreadsheet, the blue on the quality programs aggregate at risk, and we are going to start with the readmission modeling. So, and those of you who are on the phone, we emailed you the files, I believe, on Saturday. You could also follow it through your copies. So for the readmission scaling, if you scroll up just the view. All right, thank you. So we are going to discuss the state target in the next agenda item, but looking at the data, we received the last iteration of the CMS readmission numbers comparing Maryland and the national trends. We improved much faster than the national trend. However, according to our calculations, it wasn't enough for us to close the gap for the 5-year trend that we need to have. So there is still, data work that needs to be done to exactly calculate it. But in general, I think we could safely assume that we improved faster, but not enough. Given that reality, we've been discussing on the readmission program to have both penalties and rewards to increase the incentives on the readmission program and provide more rewards for hospitals who are doing better. So in the first spreadsheet, so that's where we started even in the last meeting. This one, if you remember, we had several options. So this is about how we scale, how we structure rewards and penalties, and what that amount should be. So I tried to simplify now 2 options before you. One is doing a continuous scale, and the other one is having more uniform rewards. In the last meeting, if you, again, remember, we had a lot of discussion about how the rewards and penalties should be related to their contribution, related more directly with the progress that the hospitals are making. So to reflect that discussion, we created the option 2, the single scale, continuous scale for the readmission program. So in this, I think it might be easier if we kind of look at the graph on the second spreadsheet. So the way the 2 scaling works is the original one, the red one, we determine the limits for the rewards and penalties. So in this case, let's assume the target is 9% cumulatively, 9% decrease in readmission rate. So any hospital that achieved that 9% or more received 1% reward in the scaling. So that's the red line on the top. And in the last discussion, again, I heard a general agreement to have penalties for hospitals who didn't meet that target. So then you see the scaling from 9% up to around 6%, where we had this proportional distribution of the penalties according to the declines in the readmission rate. And then we capped the maximum penalty at 2% for any hospital who has a readmission increase beyond 6%. So this is what I am now calling a uniform reward structure, where everybody who hits the target gets 1%. The continuous scale, on the other hand, is right, or above 6%. In the new one, the rewards are, I guess, two distinctions. One is the continuous reward structure. So it's right now the reward starts at 9% at the target, and in proportion to their improvement, it increases to 1%. So that's the first difference in the scaling. And the second difference on the back is, as you see, for the penalties, it's also continuously distributed, and the maximum penalty, if you keep this line straight, would hit a hospital who has 12% increase in their readmission rate. So rather than capping the penalties and rewards, this is kind of continuously distributing the rewards and penalties. Any questions so far on this one? Where is the, now I'm going to move to spreadsheet 2, RIP modeling results. And do you have, I don't see it on my side. I don't see it on my copy. The RIP. All right, maybe then we'll look at the screens if or we can get the print out in 5 minutes. But I think so. If you look at the, so this table is sorted by the better performing hospital to the lowest performing hospital. So you see McCready at the top. So first, let's look at the column B, estimated calendar year 15 cumulative reduction. So our scale is starting with 26% reduction all the way down to, I believe, 5% increase in the readmission rate. So the way I projected this is, if you remember in the last meeting, I multiplied simply the first year reduction by 2, and I got comments about the unrealistic nature of that projection. So in this case, I assumed everybody is doing that 5% annual target. So if you were to do this, then on the column Z, and if you scroll, so that's our uniform scaling. So almost half of the hospitals are going to be receiving 1% reward. And then down below, you see the continuous application of the scale. So the hospital with the lowest improvement will receive a penalty of 1.9%, because we kept it at 6%, if you remember. Do you want me to just wait for the printout, or everyone is generally following? We'll get back to it when it comes. And on the continuous scaling, you see the maximum penalty is reduced to 1.4%. And on the top, you see, again, the same hospitals are receiving the rewards, but in a more proportional way. So those are the two differences in the two scaling. So we'll get back to it once we get the printout. So on the, so this is the readmission scaling, and we should discuss the two options and probably some modifications to it. Then quickly, just recap the QBR and impact scaling. For the QBR, we discussed to move to a point-based system. So rather than doing a relative scaling, so hospitals had no idea where they are, we want to have a point-based system. So for each point, you have an associated revenue reduction or a penalty. And you'll see that on sheet number 3. what the points are, and we kind of used last year's scaling results. So we based the scores on that scale. So any hospital that had less than half a percent in the scores will get the maximum penalty, and on the bottom the rewards are 0.64 and above. And on sheet number 4, you find the application of that for the hospital-specific basis. So you'll see that on the scaling basis is the existing one, and we just apply the same thing for the 17, assuming the scores are all the same, but obviously hospital scores will change with the new performance year. Any question on the QBR?
Julie, I have a question to raise, and it's first of all, we all really like moving to the preset scales as opposed to the scaling that's been used, and especially as more revenue is at risk, it's definitely a big improvement, and we really appreciate that. That's the biggest message. Second thing is, I know it's always a challenge to figure out how to set those preset targets, particularly when this is the first time we're doing this. The concern that I have heard raised is that with the change in metrics that make up the different domains of QBR, the hospitals are expecting that those process measures, patient safety measures, where we tend to do very well on, those are now weighted a little less, and these scores are expected to go downwards. For the hospitals who have looked at them, I think they're expecting, I don't know what a good percentage number is, but a reduction in those scores. So I think that what we'll see is that where this green shading will go is much further down. So I'm just putting that out there, that I think we may want to, it would be our preference to adjust that, how that preset scale is set.
So in terms of historically, I think the HCAPS rate, 40, do you remember, Allison, what the, so there is not much change on, HCAPS was already highly rated even in this one. So HCAP is the one where a lot of hospitals are performing lower than the national benchmark. And these scores are the lowest that we've seen. In the, I looked at all the historical scores, and this is already a lower scale to start with. And as you see, the lowest number is not even 1. So the range of the score is from 0 to 1. So if you think about it, so that's the possible range, and we're already starting from one of the lowest that we had historically. So, and then since we have to have more emphasis on the QBR because our HCAPS hasn't moved, and we are already, much worse than the national average. We can look at more, but given the data lags, we can't calculate the base year yet still. So it might be beneficial to set the rate, weight based on the existing one, and then we may review it, once we have the base year data to see if it is significantly different from what we have here, but I don't expect that to happen. Yep. That's okay. You can distribute. All right, you can distribute that. Thank you. Any other questions on the QBR? Sure, Pat. Yeah, so we have some members who are really diligently working on the QBR. Pat, if you could approach and speak to the microphone.
And I appreciate the opportunity. I just wanted to share with you that actually the University of Maryland did do the demonstration of what Tracy just explained, using 6 months of data with the current indicators. And we are, and again, may I say, the University of Maryland, I use 10 hospitals. Some are high performers in the domains and others are not. But our highest score we were able to achieve was 49.
and I think this would be comparable to many other hospitals in the state. So while HCAHPS was 50% of fiscal year 15, they were based on state threshold and benchmarks, not CMS. And so therefore, several hospitals got higher scores than would in the current program. So while we know that this is a pay-for-performance program, and we're looking to improve performance, we think that many, if not most, of our hospitals will fall way below what you've identified as the reward.
Do you know what the percentage difference is between between where they were last year and where they would be now?
I can share with you all the results that we have, and we just looked at 6 months worth of current indicator performance, and be happy to share that with you.
Okay. Great. So would it help if we have a preliminary numbers and then we finalize it once we have the base year data on the scores?
Remind me, the base year data we're expecting in April, is that right?
Well,
I remember
so
there was some discussion of this.
Right, so some of this we'll have to, we were going to be talking later a little bit about the timelines for getting the CAUTI and the SSI data from MHC, but we're thinking April and May.
Okay. Without checking with anyone, I think that the answer to that would be yes. We can set something, but then agree to have a relook once we have that base year data.
Okay. All right. Thank you. Thank you, Pat. All right. While it's fresh on our tables, let's go back to the readmission scaling that you've now received in front of you. So again, if you look at the hospital-specific one, I just want to point out the bottom this time for the state. If you do a uniform rewards, it's the 20. Oh, this is an old one?
Yeah, it's where you double what they did last year. You look at the red column.
No. That red column is the actual calendar year 14 year to date. And then calendar year 15 is the cumulative reduction with the 26%. So with the two scaling, you see that the both the rewards and the penalties are lower if you do a continuous scale. So that's what I wanted to point out at the hospital level. So, in one additional item, there are some outliers that we need to think about here. So, as you see, the top 3 performers are all receiving 1% because we kept the, we started with the 20%. So, we didn't include the 2 hospitals. So, it's, it's kind of looking at the data to weed out some of the extreme cases and not have them impact the general scaling on the state level.
Julie, just a quick question. The shared savings, that's on top of this, correct? And it's a negative as well?
Yes.
And the split between the penalties and the rewards, especially as you get into the continuous, would depend on the size of the institutions that are in the top and the bottom. Is that correct? Is that why there's a negative as compared to a positive under the, when we're talking about the statewide net number?
Yes, yes, right.
I think when we're thinking about the reward and the way that we implement the reward, we should also think about the shared savings because we're continuing to take money out of the system for the shared savings. Is it comparable to, how does it play in with the rewards that you're trying to build into this program?
So I think it will come under the update discussions, but right now the model is shared savings is model 2.2 additional cuts, and so it makes up to 0.6 in total because of the historical nature of it. But depending on what we do here, I guess the policy question is which one would you want to put emphasis on? If you are putting emphasis on improvement, then the rewards and penalties should be more of the performance based on the improvement, and maybe there would be a corresponding reduction on the shared savings side for the attainment portion. So for example, we could not take that additional 0.2% if we are kind of going into a more reduced reward structure as put in the continuous scaling.
Yeah, I'm not completely sure how to answer your question, but as a biased hospital individual, you know, my challenge is that we have a readmission reduction program and an incentive built into the system that it's fairly difficult to meet that, you know, 7% reduction target that you've laid out. And even though I think we're on pace to do it this year, my net reward is currently negative the way you've laid it out, because my shared savings reduction is more than the reward that I'm getting for the readmission reduction. So I have a good program, I'm trending in the right direction, but I'm still hurt financially, and I'm questioning whether the incentives are aligned with the shared savings and the reward program that you have.
Pat, would you come forward again? Thanks.
I do have a question. I understand there was some conversation. Is there any more in the sense of looking at performance overall? So, for example, you know, our highest penalized hospital on this has a reasonable, not the best, but a reasonable readmission rate. And it's because of their past performance. So we're going to, in this model, penalize them 2% when, in fact, they have a readmission rate that's well below many of the others.
Right. We're going to get to how we are going to think about it, but what we are envisioning is to have, at the end of the year, we laid out 3 exemptions or reduced penalties. One is to look at their readmission, risk-adjusted readmission rate, and by some benchmarks, if they are lower, and they can demonstrate that, you know, that's the lowest that they can get, they would be, you know, exempted from or reduced on the penalties. The other one is Medicare. You know, if the Medicare reduction is much faster, and then there is some, we need to discuss whether we want to do it on a Medicare or an all-payer basis, but assuming it's an all-payer readmission rate reduction program, if they are doing good on the Medicare readmission rate, there might be some allowance for the Medicare performance. And thirdly, the socioeconomic adjustment. So if you develop a measure by the end of this year, and then we may need to go back and redo and look at the impact of the socioeconomic adjustment. And again, if it is favorable to hospitals, you know, we may want to consider doing some adjustments at the end as well. All right.
So can I don't know if we're fully on that topic of protections, hold harmless for the readmissions policy, but one other thing maybe to consider are the other changes that are happening with hospitals' utilization, their overall reductions, particularly if they have reductions in potentially avoidable utilization, the impact that that has on the denominator.
Yeah, let's get to it at the second one. Yeah, that's a good point too. Yeah, we have some general discussions on that. All right, so then just moving along, we did the QBR, and the MHAC for your references are laid out on page 5 and 6. Here for the MHAC, just to recap, we have 2 types of scaling, and it is pegged to the statewide performance. So the commission wanted to have statewide reduction target of 7% from fiscal year to calendar year. If we do not hit that, the maximum reduction is going to start at 3%. If we hit that target, then the maximum reduction is starting at 1%. And the scaling on the MHAC has no adjustment zone in the middle to protect hospitals who already have low PPC rates, since in general the state has been doing great on the PPC program. And the rewards are structured so that we provide rewards only if we hit the state target as well. So then I will take you to Table 7. So this is where it all comes together. What you have in yellow highlights are the maximum penalties as proposed by the staff. So for MHAC, we are proposing 3% maximum reduction if you don't hit the target, and 1% maximum reduction if you hit the target. And the rewards for the MHAC above target at 1% maximum. The readmission reduction improvement program, we are proposing to have 2% maximum penalty and 1% maximum reward. And for QBR, we are proposing to have 2% maximum penalty with the changes that we discussed on the scaling options. And as you see, we modeled the shared savings as another 0.2% additional reduction. So that gives us on a hospital-specific basis for the hospital with the highest risk-adjusted readmission rate at 1.3% maximum reduction. And that's what Justin was speaking to in terms of adding those together. And we have additional adjustments related to quality in the demographic adjustment. These are the potentially avoidable utilization reductions on the allowed volume growth. And when you add them all up, the contract stipulates that we will be at or above the national quality program's risk value. So once you total them up, the Maryland comes with, if you add all of it, is the 9.2 at the middle row, some with PAU. And for the Medicare, they have only 3 programs. That comes to 6% in total. If we accept all these proposals, then the difference between Maryland and the U.S. would be, including the PAU, is at 3.2% cumulatively. The reason, I guess I should go back a little bit to explain, we are discussing with the Cmmi staff how to do these calculations, and there is a concern from the Cmmi perspective to include the PAUs, especially PQIs, because in their world they are looking at PPCs, readmissions, and the VBP, and there is a question about how equivalent it is once you add the PAU and the PQIs on top of the 3 main programs the CMS has. So that's why you can see the 3 different calculations on the spreadsheet.
So is what you're saying about the PAUs and the PQIs in particular is that it's not that they have an issue that they're part of our system, that we're looking at them, that we're at risk for them. It's they think that that shouldn't be, because they don't have a program on that, then they're saying that we're not comparing the same things if we include them. Is that what they're saying?
Yep. Well, they also raised the question about the PQIs, but you know, there is no corresponding PQI-like measure in their quality programs, and I don't think they are planning. They think PQI is more of an ACO measure, and we've been saying that we are a statewide ACO with 600,000 enrollees. So maybe in terms of the rationale and what we had last year, for the MHACs, you see a reduction on the maximum penalty because we are doing better. On the readmission program, our rationale for proposing 2% is we need to increase the incentives on the readmission, and hopefully that will impact the performance. The QBR, we have concerns with our HCAPS performance. We are doing good on mortality. And in general clinical measures, but our HCAPS are much below, and we think that we need to increase the percentage risk on QBR and focus more on HCAPS. So then the other side of the table, once you add all those up, since we removed the revenue neutrality requirement from our programs, we need to be also looking at the overall net impact of these programs on the update factor. And as modeled so far, if you look at the percent total revenue, once you add all programs, and if we didn't hit the MHAC target, you see the impact is close to 1% of the total revenue as negative. And if we hit the target on MHAC, then it is reduced to 0.3% of total revenue in the state. And from the hospital perspective, we heard concerns about having these raised, increased at risk penalties associated, and the inability to manage from year to year the impact. So we've been discussing to have an overall protection for the maximum penalty. And as you see, the highest penalty, once you add them all together and as modeled, for one particular hospital, the maximum penalty would be 1.5% inpatient revenue. And if we hit the MHAC, it is 0.5% of inpatient revenue. Mm-hmm. Yeah, oh, you know what? Sorry. So that's 4.4 is the hospital-specific one. Yeah, that's the maximum, right? 1.5 is the total statewide, and then it's reduced to the total revenue. So one hospital could get 4.4% penalty as a percent of their inpatient revenue. And they are all coming from Table 8, where we put together all the adjustments together. Yep.
So, Julie, I guess at the risk of repeating myself, I'll first say that the first part of my comment has more to do with the carrot and the stick. I think we recognize that the readmission reduction program, I think in your words, needed to add additional incentive. My challenge here is that I see additional penalty more than I see additional incentive. You've taken it on the negative side as opposed to the positive side. And I think this might actually have the opportunity to link it back to both Tricia and Dave's point about the balanced update factor, because if you look at those individual factors, I don't see any positive rewards for quality indicators. So if you're looking for additional areas to build in balanced update adjustments, that might be the area. So I guess my question when I'm looking at this page is I'm looking at the readmission reduction program and the shared savings, and I look at those together. You have pretty sizable reductions on the penalty side with not much on the reward side. So if you really wanted to add incentive, I think you could put more reward in there, and I think you could actually put extra dollars in the balanced update for good quality measures as opposed to just taking it away from folks on the downside.
So on the, for this year, I think we haven't calculated, but there is the additional MHAC. Always my modeling is kind of on the side of the negative so that we are protected, but the actual performance usually comes much better than what I modeled, and I'm hoping that will be true again. So the reason why I think the readmission is happening is because of the way the scaling work on this one. So the maximum penalty we increased from 0.5 to 1%. But the way that it is doing continuously, obviously the 1% is applying to the very end of that spectrum. So if we can find a way to increase or redistribute that penalty, so we are kind of in the balancing act of not having a significant change with the a minuscule change in the reduction, right? That's the jump from 1% to 0 with no differential change in the performance, versus having a continuous scale and then have not significant rewards for the hospitals that are right above the target. So if you could find a way to balance that in a more reward side, I think it may address your concerns a little bit more. Barbara?
Certainly that might help. I think I am still stuck also on the introduction of PAU, PQI, because the emphasis this past year was really on the true quality results, which have a huge impact on the cost of care, and that was MHAC as well as readmission. And to see PAU, PQI introduced at this point with no reward is concerning, because we are still, as a state, trying to look at the true cost of quality, which continues to be MHAC and also the QBR. Now, the QBR, I also understand we have some concerns because of the makeup of the 1.0 and the 2.0. Some of the indicators are changing this year. So I would hate to see us go on to PQI and PAU at this point, and I'm a little bit surprised to see that. I know we've talked about it in a global way, but I would say that we're not really ready to take that on as possible.
So the way the PAUs are working right now currently is it's under the demographic adjustments on the global budgets. So what we are doing in basic terms is we are trying to estimate what the volume growth would be based on population growth. And because of the aging, we age weight those growths. So the statewide population growth is 0.6. Once you add those age weights, it jumps to 1.2. So what we are seeing in the PAUs is as we are controlling the per capita cost, you would want efficiencies from that age-adjusted volume growth. And the way we take that efficiency is by estimating, basically we are not giving any increases on the PAU. So you can keep your PAU at the same level, so you're not losing any revenue. What we are not giving you is any growth on the existing PAU level. So it's a very limited impact currently. But the reason why obviously we want CMS to give us credit for it. So that's why it's part of the calculation that you see here.
So the two adjustments, the shared savings and the PAU, are not performance-based. They're adjustments that are being made within the context of the update factor calculation. Is that accurate?
Partially. Right, because your adjustment is still based on your PAU % of a hospital specific, so it is a performance-based, and also on the shared savings too.
But not performance-based the way the other metrics
exactly
are.
Right. Right. Yeah. And timing-wise, they are done prospectively. These are done retrospectively, and that speaks to the performance-based a little bit too. Pat, do you have a comment?
I just have a question, and it's actually going back, so I apologize, for the MHAC adjustment pieces. Am I reading this correct, that even an 8% improvement is penalized?
The maximum penalty for an 8% is 1%. So a hospital who would have, if you go back to that MHAC scaling, if a hospital scores at 0.17, then the maximum penalty is going to be 1% for that hospital, even if they achieve statewide 8% reduction.
So I think I'm going to pick up on that too, because I sort of missed chiming in earlier. Looking at the MHAC modeling, if I understand right, we have the scores for FY 2014 with the new benchmarks kind of built into that. And if you assume an 8% improvement, that gets us to those green columns. And then I think maybe where Pat was going was down at the bottom, when you add up all of the positives and negatives with an 8% improvement, which means we've hit the statewide target for the year, and we've probably hit the 30% over 5-year target, then there's a $24 million penalty to the system. So I think that's the piece that doesn't feel like that the payment scale is set quite right, that if we're hitting all of our targets, then it should be at a minimum of 0, but probably, to Justin's point earlier, a positive. So rather than changing the 3% and the 1%, but how those are, I don't know how to say the word.
Distributed?
Yeah, distributed, yeah.
So it is a function of, if you look at, in that case, I would look at the maximum applied, maximum penalty and the reward. So in terms of the maximum penalty, we modeled 1%, applied is 0.6 for the worst performing hospital. So in terms of, the reductions, it's less than, it's around 0.5 percentage point. On the reward side, you see the 1% applied to the 2 hospitals that performed better. And the reason why you have the it shows like a penalty is because some of the big hospitals are on the negative side. And if you look at this year's, they are on the positive side. So they are impacting the overall total rewards in the state.
Is the scale on, I guess it's page 5, handout 5.
Mm-hmm.
Is that scaled under the newly based numbers?
So we did look at the new scores.
I just wonder if that's causing the disconnect.
When we looked at it, it actually didn't change much in terms of the scores. So if you look at the base 2014 scores, so if we had refreshed it, then the maximum penalty would have applied to 0.19. Instead, we kept it in the old scale, so it's actually starting at 0.17. So the disconnect is the way the modeling is worked. 8%, even though 8% is a good improvement, the impact on the scores will be much different than what you're seeing here. We did a very linear improvement rate. I would encourage you to go back and check the modeling that we did last year, and you see all our hospitals shifted to the pink areas with the improvement that we saw. In this case, we are kind of shifting everyone almost on a linear basis to the color zones.
But last year, didn't everybody increase to the pink because it wasn't 8%, it was 27%?
Right.
So if you assume that that's a one-time phenomena, and they will increase more like 8% on the average, I think Tracy's point would be just look at the sheer number of negatively applied hospital penalties compared to the 4 or 5 down at the bottom that get a reward. Again, I think the message is just a question, which is if the state's meeting its target, why are you penalizing hospitals so severely for meeting their target? It just feels uneven.
Sure. If you, because one wouldn't expect an across-the-board improvement, right? So if you modeled it instead with the hospitals that were lowest improving most, you would probably get a lot less negative number there, right? So it all depends on the distribution of the change, not just the average. And I don't know what we could, what we could do about it to make sure that the system as a whole weren't being penalized, even if we met the total statewide target. But it really depends on how it plays out.
And the other thing is the distribution of the PPC rate. Even though we had an improvement, there's still large variation. So some hospitals are still performing significantly worse than the benchmarks. So that's also the function of the absolute PPC rates once you adopted it. Barbara?
Yeah, I think that, first of all, we all know that hospitals pulled out the stops last year to improve quality. We got the message that the MHAC had a huge impact on the cost of care. So we way exceeded the recommended reduction rate. And I think also you had said, Shule, that there was a certain amount of adjustment for documentation, POA, et cetera. But most hospitals got to, quote, the real quality. The concern, frankly, is also the amount of resources the huge amount of effort it will take to go further. And it does feel that the pacing that we had originally for improvement has now really escalated to the point that it may not be realistic. It almost turns some of the PPCs into never events. And we already have 5 of those. But I mean, the current calculations and the projections for the year would make this very difficult for most hospitals to achieve.
This is Pat again, and I just need to, your comment about we have many hospitals still with a significant gap compared to benchmark. I think we also have to be very careful not to assume that every hospital safely can hit that benchmark. Most of those benchmarks are achieved by hospitals with not necessarily the complexity of care that other hospitals have. And they are potentially preventable, not absolutely preventable. So I think we're holding your more complex hospitals at a higher standard.
I do think that's a very important point. Remember, the PPCs range from 6 for the hospital with the smallest average daily census up to 65, and only 3 hospitals have 65. And there are many in our small state with less than half that. So it makes it very difficult to severity adjust and to consequently put a target together. But I think we have to look at that.
So in terms of the way it's working right now, you see in black the cutoffs for the penalties. And we kind of modeled so that it was the median in the previous one. So as you see, as you improve the number of hospitals, it moved from, the penalty zone moves from 0.5 to 0.46. So I just looked at quickly, you know, if you move it to 0.4, you know, I think it's hard to it's hard to predict what the distribution is. So we just use the base year, and then we use the median as the cut point. So, and I do agree with Stu that this is very unlikely scenario that most of the time the worst performer hospital is going to be achieving better results, so you're going to have much fewer hospitals penalized. So I would look at the maximum penalties rather than the overall state impact. So the maximum penalty for the worst performing hospital right now is going to be around 0.6, as opposed to the Medicare one, which is 3%. Someone on the phone had a comment? All right. Stu?
Yeah, it might be helpful then if you, because you have some historical data on the degree of improvement by hospital. So you could either look at, you know, project like the same distribution as you've observed in the last couple of years, or you could make the assumption that the worst performing hospitals, you know, like a sliding scale assumption, just to show what the impact is on the total.
Any other comments?
I guess I'm thinking about one more year out. If what we're doing this year is based on looking at the distribution in the prior year and taking the median as where we make the penalty or no penalty point, what we expect to happen is that as we're doing all of this work with the clinical groups to understand the PPCs better and what hospitals are doing clinically to improve, to reduce harm, what we're expecting is that hospitals will all tend to move to the right end of that scale. But like Pat was saying, there are potentially, so I don't really know how far everyone can move and whether they can really move on every PPC. Because if I remember right, looking at the different PPCs, some of them the performance can tend to cluster, and others they tend to be more spread out. So I think what is concerning a little bit to me is that when it feels like when we take the prior year and just advance it, we're assuming that we can just keep on moving like it's a linear improvement. But I think if we do have a good improvement next year, and let's say hopefully when we look at the actual final results that there'll be a much bigger pink area than there is a green area. But then what do we do in the following year? At some point, if we get most hospitals performing where we really want them to perform, we're not going to be able to construct a scale where half the hospitals get a penalty. So I don't know if you've thought about that at all, or if that's premature, but that's kind of what's in my head about looking at this.
Yeah, so we didn't change the scaling this year. We didn't move it forward a year. Based upon the discussion here. So I guess I'm wanting to make sure that's clear to everybody. We kept it the same from the base year scores from the year before.
Kept the scaling the same, but you rebased.
Yeah.
The scores are rebased with the new weight.
So the scaling is not changed with the base.
Yeah. So just baking in all of that improvement that happened up through June means that that's a lot. It's harder to hit a benchmark now because it's a different benchmark, it's a different threshold.
So in terms of the kind of looking at the distribution, there could be two developments coming up. So CMS is looking at the Medicare claims. I know we have issues with them, but creating some national benchmarks. So, then once we have national benchmarks, then you don't have to have, you can base some of these on the national averages or the distribution, so that way more hospitals would have a chance of receiving rewards if you're doing better than the national, so increasing the number of hospitals that we use in the measurement. The other one is, we are planning to look at the distribution in a more systematic way, and in the QBR we had that topped-off concept, right? We removed the measures if the hospitals are clustered in a good performance all the way on the top, and there is not much improvement because on the QBR measure it's a percent base, so it's 100%. So we had a good estimate of what is doable, what is not. So we can start thinking, and I would appreciate the clinical work groups to work on that, to look at each PPC and try to say kind of, okay, this looks like a topped off, and maybe we have adjustment for individual PPCs where it is close to no event basis. But this year, I think looking at the distribution, Commission wanted to have the 8% reduction, 7% reduction, excuse me. And last year we had 7%, and corresponding number is 5%. So we significantly reduced that target, and we are reducing the maximum penalty to 3% if we don't hit it. So if we could lower it more, but at the same time, PPCs are something that we are comfortable, and we don't want to lose the momentum that we had last year. So if you reduce significantly the incentives around the program, I would expect the attention is going to move away from it too. I think one more year is how we saw it, that next year we may have big changes in the methodology if we keep continuing to improve. All right, maybe we are going to talk more about the readmission, and if you have, once we have that discussion, we can go back to this, or any other comments? All right. So we are going to move to the PowerPoint presentation on the readmission, so you can see the numbers on the trends. So on slide 2, what you have is the revised national and Maryland trends based on the Cmmi data. So as they are revising the readmission measure, and in terms of revisions, they are cleaning up the denominator, and they implemented the planned readmission logic to both national and Maryland numbers, what you see is the difference on the calendar year 2013, that's our base, between Maryland and the nation is 8%. So Maryland's rate is 8% more than the national number. What we were questioning and uncomfortable was the significant change in the trend in 2014 data. As you see, for both national and Maryland, you have around 3-4% declines in the rate, and suddenly on 14, you see a 0.3% for the nation and 0.8% for Maryland trend. So taking these trends, looking at our data, you'll see that we feel more comfortable now with the trends because that's what we see in our data, and we are also trying to get a confirmation for the national trend. But once you do the calculation, we should have improved by 1.8% this year to match up the national trend and close the 1/5 of the difference between the national and Maryland readmission number. So one question that we were looking at is the observation state, whether the 2 midnight rule had an impact on the trend. And there is some impact that, as you can see, on a monthly basis. And especially the initial 13, July, September, October, you see so this chart is showing the readmission counts if you were to include observation cases 24 and more in the algorithm. So they can be an index, they can be a readmission. So what would the readmission trend would be if you have them in versus the red one that we are using in the program, which includes only the inpatient cases. So in general, I think what you see is the red is lower than the observation, so our decline is less once you have the observation cases. And except one period where there is a big significant difference between the trend with observation and without, you see the trends are running parallel to each other. So on slide 4, what we modeled is if we assume that the trends are going to continue, what should be our 15 target on the Cmmi trend? In here, what we did is we built all the difference that we had in calendar year 14 that you saw into the 15 rate. So for 15, assuming, I guess the biggest question here is what the national trend is going to be. So here we just took the 2 most recent years average for national, 1.3. With that assumption, you see that the required reduction for the Cmmi is going to be 3.9. And we did different modeling for sensitivity analysis, so you'll see those numbers in general. But the modeling approach we took here is we built all the difference in calendar year 14 to calendar year 15. Then the next step in modeling is to predict how our data is going to move. So our modeling originally starts with the Cmmi data. That includes all Maryland hospitals and readmissions happening everywhere in the nation. And our data, as you know, is only includes the readmissions happening to the Maryland hospital. So there is a data source difference between the 2 trends. And the second issue, so that's the difference between Medicare fee-for-service and the Cmmi data that we received. So as you see, the 2014 trend is exactly the same as what we got from CMS, 0.8% reduction. And when you do a case mix adjustment on top of it, you see that the decline is actually much faster with 1.3%. And in the hospital performance, we have to do a case mix adjustment. So if you were to use just the Medicare trend, then the numbers that we will be looking at is the case mix adjusted trend from the HSCRC data. we've been using all payer trend, so then what we need to do is to move from Medicare specific trend to a required all payer reduction trend. And you see that in the highlighted column, the all payer case mix adjusted numbers are improving much faster than the Medicare one at 3.7% for calendar year 14. I would point out that the trend is new. When you look at the 13 data, Medicare had a significantly more improvement than the all payer. So that's 4.2 Medicare unadjusted reduction compared to 3.2 all payer case mix adjusted. And you see that trend change this year, which may have a significant implications for the program. And at the bottom, you see we averaged the two and calculated cumulative difference between the two. So when you bring all these together, what that means. So we start with the Cmmi Medicare numbers. And again, just based on one methodology or one number, we are projecting to have a required reduction of 3.9 on the Cmmi trend, which will cumulatively get us to 4.6% Medicare unadjusted target. And when you add the case mix adjusted trend to it, then it will increase to 5.7%. And on top, if we do it on an all-payer basis using the ratios between the two, the cumulative all-payer target is going to be equal to 9.3%. As you see, the Medicare is risk-adjusted is declining 0.57%, lower than the Medicare unadjusted, and the all-payer is declining at 1.9%, faster than the Medicare unadjusted. So all we are doing is adding those ratios to the Medicare base. So we were, looking at it, we were concerned with the difference between the Medicare and all-payer readmission rate. So this chart is showing you the monthly trend. So the red line is the Medicare unadjusted HSCRC trend, starting with calendar year 13. And as you see, for the most part, the all-payer Medicare red line was under the all-payer number until December 13. And since then, the all-payer number decline is much faster than the Medicare decline. And I suspect this is related to the additional Medicaid utilization that came in with the January data, but it could be other things that may explain this. But the trend is, in general, to me, is, except 2-3 months, is stable, that the relationship is still strong between the all-payer and the Medicare numbers.
Yep. Can I ask you a question just on what exactly we're looking at? Mm-hmm. Monthly trends, annual change. I know in some reports we look at 1 month compared to that same month in the prior year, and then in other ones we look at like a year-to-date or a sub-to-sub.
So this is month-to-month, looking at the last year. So that's comparing January 13 to January 12.
Okay.
Readmission rate.
Okay, and we don't add those months up as we go. Okay, gotcha. Thank you.
So as I said, we did model. So this is kind of, once you understand the methodology, this is the different national trends. So the important thing here is what we expect the nation to do in calendar year 15, and then build on top of it what we need to do. So we modeled 4 scenarios, kind of trying to get a sensitivity analysis. So if you assume that the Medicare had the lowest improvement rate that they had in the last year with 0.35%, then our all-payer required reduction would come up to 8.3%. And on the end of the scale, if they did the highest improvement that we saw in the last 3 years, which is 3%, then the highest that we need to have is 11% on an all-payer basis. 10.9.
And this is putting all the improvement, all the missed improvement in year 1 into year 2.
That's correct. Let me just, then, trying to project that, we looked at the monthly trends and see what is happening with, so are we likely to see another 0.3, or is that going to be just a dip that they saw and then now it's going up again? So in this case, we projected we plotted the national Medicare versus the Maryland readmission rate on a month-to-month basis, again comparing the month with the previous year's month. And so the red line is the national trend, and declining is a better improvement, as you can imagine. As you see, it slowed down a little bit in January to April, and you see the reduction in the September to October period. So it's really not clear where they are going to land. So you don't see a general trend of going down or going up. So it seems like more of a fluid trend of up and downs, and some of it is the seasonality, even though month-to-month should take care of it. And on our trend, again, you see the declines happen mostly on the 13, and 14 seems to be more slowing down for the Maryland trend. So I think I would I guess you didn't need to look at this. It is safe to say they're not going to reach probably the 3% reduction, but I do think that they're not going to be at 0.3% either. So we discussed the denominator, so I'm just going to go through all of it, and then we can go back and look at them together so you have a better sense of the whole picture. So we've been discussing the denominator issue. So the issue here is, since the readmission is measured as a per discharge basis, what happens if your denominator is going down, right? In an unadjusted world, if you reduce your admissions, your rate is going to go up, just holding everything else constant. What we are showing here is, though, since we are using a case mix adjusted percent, our expected numbers are already taking into account those reductions in your denominator. So in this case, we have an example hospital, and we put the DRG so you can kind of see the changes in the denominators. But looking at the highlighted columns, if you didn't have any adjustment, this hospital was showing 0.13% increase in their readmission rate because their denominator is declining by 14.5%. But once you do the risk adjustment, the risk-adjusted rate decline is at 1.6%. And the reason is because we are using the weights and multiplying them with the discharges in the base and also in the current year. So your expected number is reduced by the same percentage as you would have in the two time period. So with the case mix adjustments, we think the denominator issue is not as serious as the national and the Maryland specific numbers, but it may still impact the declines if you think that the case mix adjustment is not enough and the people who are staying at the hospital has higher readmission risk than they had in the base.
And
yep.
You use the term risk adjusted. Is it risk adjusted
case
or is it
mix adjusted? Right. Then we looked at the issue about the socioeconomic adjustment. So we're still working through, and we need to work on trying to find an appropriate way to adjust for the socioeconomic factors and demographic factors. But we still feel comfortable since we are using an improvement base. So in this case, we just use the DISH percentages. I know there are some issues with it, but it's like a general aggregate measure, and we are looking at the adjusted rate by DISH percent and improvement rate by this percent. You see, in general, there is some positive correlation between the more DISH you have, the higher your readmission rate. But on the improvement scale, it's kind of distributed all over the place, so there is not much relationship between the DISH percent and the improvement rate. With that, rather than kind of develop a solid methodology and try to estimate what the impact of the denominator is, what the socioeconomic adjustment is, which we don't have currently, what we are proposing is to have these rules and then develop with the industry this year how we would apply it. But if a hospital proves to us that the denominator changes impacted their case mix adjustment rate, then we would look at the the reward and the penalty, and then reduce the penalties or zero them in. Again, on the high performance on attainment, if they can prove that this is the lowest that they could go, and they couldn't achieve that 10% because they already had the low readmission rate, then we are considering to exempt them from the penalties as well. And lastly, I think there is a larger policy question that is difficult in my mind to think. Do you make your payment on a Medicare readmission rate, or do you still keep it on an all-payer basis? From the staff perspective, our whole hypothesis is we could do equal or better than the Medicare with an all-payer system, right? So we are saying, well, we will apply our measures on an all-payer basis, and we are testing whether we could beat the Medicare targets. So that's kind of the more conceptual reasoning. On the pragmatic reasoning, Medicare numbers are still moving, so we are still working on creating a solid measure on the Medicare readmission rate. So even though we missed the Medicare target this year, we also missed the all-payer target this year. So if we catch the all-payer target next year, we may catch the Medicare by then. And as we are working on the Medicare-specific numbers, by December of next year, I'm anticipating to have a solid Medicare measure. We still have some work to do with the Medicare numbers, so we will feel more comfortable keeping it on an all-payer basis and reconsider it for calendar year 16 if we end up missing. So those are the pro comments on why we should keep it on an all-payer basis. On the Medicare side, I kind of see the logic there too. Well, you are measured on the Medicare readmission rate. You missed first year. Keep it simple. Put it on the Medicare side. Again, I think it is a more general policy question, and I think from the staff perspective, for those reasons that I outlined, and also considering the change is not only a change in the measure, but also in the strategy a hospital would develop and implement, it will have a longer-term implications for every admission policy. So staff will be leaning towards still recommending it on an all-payer basis and leaving it to the commissioners to decide whether they would like to make the change to a Medicare-specific one. So I'll open for discussions. Maybe we start with all-payer versus Medicare first. Yeah. Well.
Again, I think from Care First standpoint, obviously we're concerned about the hospitals doing a good job across all payers because it would affect Care First beneficiaries. But in this case, it just seems, to your earlier point, that we're really pretty far behind on the Medicare-specific test. There's significant consequences associated with missing that and failing that test and losing the exemption. I just personally feel, and I think this is also representative of Care First's position, that loss of that autonomy to set our own policy with regard to a pretty significant reimbursement aspect of the system is quite significant, and that's a very negative consequence. It just erodes our overall autonomy. It means moving to arguably a set of standards around readmissions that are far more limited than what we're trying to do. Are obviously challenging to the industry, but beneficial overall. That it's all-cause readmissions with the exclusions that you have. And we're running out of time. I just think that it's fine to say, well, let's wait another year, but I'd say it's do or die this year. Either you move to Medicare specific specific and try to get a chance of actually attaining that test, or then you only have 3 years, and you may have slipped even more, in which case the makeup is even more significant. So I understand the long-term, potential negatives of moving to Medicare specific, and that it may not, mean that we're going to be reducing all payer readmissions as rapidly. But you shift to the Medicare specific readmission program, that's forever. And as I said, I think it's a very negative circumstance for the system.
Yeah, I think the points that are in our head, I really do understand the idea that if our target for the waiver is Medicare and it's unadjusted, that tying a payment policy to that is definitely the clearest connection. You don't lose anything, particularly when we look at how close the HSCRC data is to how the Medicare data runs. Obviously, that's very close. From an on-the-ground perspective, the advice that we have given to hospitals and that they have done is on readmissions is to have broad portfolios of policies, not to have their policies address their patient population needs, and not to structure their policies from a payer-oriented perspective or even a diagnosis-oriented perspective, but from what the main issues are in their patient population. So changing to a Medicare-only target will shift those priorities. If the payment policy is tied just to Medicare, it will shift those policies. We have taken a look at what the rate of change is in readmissions by payer class, and you may already know this too, or Trish may know this, but by far the biggest reduction percentage-wise has been in Medicaid. So I think that was, when we looked at FY13 to 14, there was an 11% reduction in Medicaid readmissions. So that changing that payment policy to Medicare only, except for the incentives that are inherent in the global budget, it adds that big incentive just on Medicare and takes it away from that all payer. So as we've talked about it, our hospitals that are doing Medicare readmissions and all-payer readmissions, that's how their programs are structured on an all-payer basis. So this would have a significant impact. I think what we would like to see is continue with the all-payer target for another year. Readmissions change relatively slowly, so I think we'll continue to see improvement. We can monitor this throughout the year by looking, even using HSCRC data. Currently, when we look at monthly data, we look at it on an all-payer basis. We can start to look at it fee-for-service unadjusted and have pretty good confidence that that's probably how that test is looking. We can look at that through the year, and we can look at the all-payer through the year and make sure that it's on track and then reassess. I think, I mean, we're sort of speculating a little bit about what would happen if we miss a Medicare target, a Medicare readmissions target next year. If we miss it by a lot, that's a big problem. But as we can see even with this year, we're not missing it by a lot. We're missing it by a bit. In my opinion, and this is just opinion, a speculation, is it a big issue? If we're presenting to Cmmi that we have missed our Medicare readmission waiver target by a little bit, but our all-payer readmissions are down significantly, our Medicaid readmissions are down significantly, that's a very good story to tell. It's the right thing to do for patients, and we know that depending on how you measure readmissions, you get different answers. So the test is defined as it is defined in the waiver agreement, and we're going with that. But I think if at the end of a second year, if we can present to CMMI that we've made good progress on all payer readmissions, I think that's a good story too. So that's how our thought process has gone.
Is it true that, I know that they gave a flyer, but next year if we don't meet this, they could
When did I turn it off?
I turned it off.
So this year, because the measure wasn't developed and revised, they are not going to use the first year results. So for next year, we either have to pass what they are sending us or the revised one. If either of them we pass, then they will consider us as a success. I need to refresh, but my recollection is if we don't pass, then we need to submit a corrective action plan. No, we are not going to automatically go to the national program, but we will explain the trends. As Tracy said, I think that's a story that we would tell if we are successful in other payer categories, and also what next steps that we are taking to ensure that we are going to hit the benchmark for the upcoming year. David, I think you had a comment.
Yes, just
to build on the other thing that, this is Donna, the other thing that we're allowed to look at is what's happening with our per capita and submit information on that in case our per capita is falling much faster. So, for example, if we were really reducing readmissions per capita much faster, that would be something that Cmmi would look at. I think right now our per capita readmission is going down a little bit faster than our percentage. Is that right, Julie?
Yes, so it's still, it's not enough, it's the same story. It's not enough to close the gap, but it is going faster than the national trend as well. Yes, David.
Yeah, and I think to build on what Tracy was saying, I mean, it seems to me the hospitals are already looking at doing things from an all-payer strategy. And on behalf of the employers and other stakeholders that are really driving the private payer side of the equation, I mean, I think we would love to see the continued focus across the board. I don't know if Jim would agree from the constituents he represents, but yeah, if we can keep the focus on the all-payer, that would be ideal.
Okay.
What, in addition to some of the other things that Julie talked about on the Medicaid side, I know one of the things that some of the providers really focused on was to focus on the behavioral health integration and community-based strategies to try to reduce readmissions in the behavioral health arena, and that appeared to be very successful. So, there is a concentration of behavioral health readmissions in Medicaid, and then when you get into the commercial side, there's more of a concentration of quality-based issues. So, I would hate to see the reduction of focus on behavioral health or the quality-based readmissions. So, I mean, I think those are really, really important.
Tricia, would you like to add anything?
I agree. It needs to be all payer, and we need to keep that focus.
So then, well, we will kind of see. So then going back to the scenarios, maybe let's kind of review if you look at then the all-payer, the target has to be between, something higher than 8.3% and something lower than 11%. So that's the range. It's a big range. So any comments on how we can look at it differently, or how we should approach setting this? So it's on slide 8. As you see, the 2-year and the 3-year average, the 2-year is producing 9.3%, and 3 years producing close to 10%. And I think what was helpful to me is to look at the 2-year differences. So for 14 actual, you see that our current performance is 3.8%. And since we didn't meet it, obviously we need to strive for a higher performance on the 2nd year. So then the question is, do we strive for a 1% higher, 2% higher, or close to 3% higher. So I think what is achievable and what is required, so kind of looking at from both perspectives. One is what is the math tells us, and the other one is looking at our performance first year and what we can achieve on the 2015 rates. Could give you a kind of how realistically or how hard, I should say, hospitals need to work. And you wanted to round these up too, by the way. So, yep.
I would just say that I think, just echoing your comment, that the 3.1 is probably not realistic. So that's probably not the one that you want to focus on. So I would say, obviously, in the 0.35 also is not realistic. Mm-hmm. So obviously, you're focusing on the two in the middle. Particularly since you're not leaning towards using Medicare specific and you're going to rely on the all-payer to drag up Medicare, I would argue for doing something on the higher side for a cumulative target.
One thing to consider, though, it seems to me like the best strategy for getting your all-payer readmission rate down is to focus on patients with multiple chronic conditions, and that is describing the Medicare population. So it may be the other way around. I mean, it may be that the best way to get your all-payer readmission rate down is to focus on Medicare patients.
Mm-hmm.
I don't disagree with that.
Yeah, that's certainly true. Like the big diagnoses that pop to the top of all of the list, the heart failure, COPD, pneumonia, hugely prevalent in the Medicare population. And I think that works when we look across the state. One of the things that concerns me a little bit, and where I think the policy needs to be a little more nuanced, is that we do have hospitals that have they have different mixes of payer, their mix of patients. You know, Western Maryland may have 80, 90% Medicare, Bon Secours 50% Medicaid, and everything in between. So I think, I mean, I'm agreeing with you.
The reason I pointed that out is just to say that there may not be that much of a discrepancy between the two approaches. I mean, I agree. I think that the all-payer approach is the best approach, but they're not in conflict with each other.
Shuli, this is Michelle. I've got a question for you. Just back to that point that was made earlier in the MHAC conversation about just the pace of change. And am I reading this right to say that the Medicare FFS unadjusted and also the case mix adjusted have slowed down in terms of how fast they were able to move the dot? So I'm looking back on page 5, where between 13 to 12, there was somewhere in a 4% reduction, and then when you look at 13 to 14, it slowed down quite a bit to just a, you know, let's say plus or minus on the 1% reduction. And if that's the case, then do we have an opportunity, if we just keep steady, to make up some of the gap that we're talking about, so that this even our estimates on the 2- and 3-year average could be a little skewed? Just trying, you know, I've kind of got this sense that there's a lot you can do in the start of an initiative, and then it does become harder to move the dot at that same relation of change. So just a thought here as we're looking at these numbers.
Yeah, Michelle, good point. So yes, the trends slow down, but if you go back to slide 4, we have 8% gap in our base that we need to close. So that's why looking at the national trend slowed down too. So it's a good news. Seems to be a general, you know, there could be a general reason behind slowing down, right, both for national and our trends. But we still have to do much better than the national, and if you just add those 8% differences between Maryland and the national and divide by 5. So we should have improved at least 1.9. So it's not catching up to 4% that we see in 13, but we should have had 1.9% improvement, and we are kind of half of that. So that's the issue, that we still need to do better than the national trend. And you know, the 0.3 reduction that we see on the national one, who knows what's going to happen next year? Frankly, I think people who would know that answer would earn a lot of money. I will give some. So
I mean, I'm sorry,
Donna, go ahead.
No, I was just going to say, you know, I think that it involves developing new tactics. So Cmmi said, you know, they hit the wall on readmissions, but then they went on to new tactics of really focusing heavily on reducing admissions and readmissions from nursing homes, and Mosaic is taking patients with 8 or more admissions with mental health conditions, and they've cut the admission rate in half. And so I think it's about finding new tactics and moving beyond just you know, the same tactics.
And on top of it, I think when you look at our trends, we saw a big decline in the last quarter. So that was kind of what we heard from the hospitals. It took us a while to implement these strategies. We are just going off the ground. So I expect that our trend would speed up in the coming quarters as well. You know, we haven't had the national corresponding number for it yet, but we may be closing the gap even faster than what we did in the first half of the 14. Any other comments or questions?
Can I just simplify this? Are we really looking at 9% versus 10%? That's the decision. I just want to make sure when you say rounding, which way. You said rounding up, and I thought, well, if we're just rounding up, we're talking 10.
9.5 is a middle number, round enough, maybe.
Okay.
Yeah, I was looking at the 2- and 3-year average of what we thought we needed to do in calendar 15. So I was rounding those numbers up in my head to come to like a 9.5, and I guess a
10%.
10%. I mean, considering I think that that we know that the national trend is slowing in their rate of growth, I think a 2-year average is a better indication of where we think they might land rather than a 3-year average. And to the discussion that we had earlier about there's a gap between the all-payer and the Medicare only, that gap may start to close up, and those trends may start to be much more parallel as we continue.
All right. Any other final comments? Anyone on the phone who has additional comments? So with that, I think we are going to move to the QBR program. And yes, Bob?
Just, we talked earlier about the scaling. Any last-minute thoughts there in terms from staff in terms of, you know, the proportional versus the kind of the, you know, you get one readmission over the threshold and then you get a bonus of 1%?
So we are leaning towards more continuous approach on the scaling. But, you know, so we want to add the shared savings on top and maybe show the cumulative impact and make sure there are enough rewards for hospitals who are performing better than the benchmark. Would be the approach that we will take.
I think just to that point, you know, again, I see, you know, that is a big jump to go from, if you improve 9%, you get nothing. If you improve 9.1%, you get a 1% bonus. So I see that. But I feel like the blue line is too steep. So I don't know if we can make that an S-curve, or am I getting too complicated? Just because when we start getting cumulative numbers of improvement of 16, 17, those numbers are just so big. I feel like other trends are going on there. So maybe like to make that the first part, so make it, you could call it, I don't know what you want to call it. I drew a little line there where it's a steeper and then it levels off rather than straight up and over or complete hypotenuse.
You want to make it a concave form?
Yeah, yeah. Just a thought. Just a thought. But this could change when you look at the impact with the shared savings. I don't know how that's going to look.
Wasn't that what we did at the first year of QBR? We did that.
Concave, right? Just to clarify, with the shared savings, what are you planning to do?
I will add the numbers, projected numbers, and calculate the total impact that they are going to have for 17, which projected for. And then, so find a way to make sure the rewards are rewards that the shared savings is not eating up even on the 10 to 11% improvement hospitals. All right, so we are ready to take a deep breath and then move on to QBR.
Great. Thank you. This is Allison, and I apologize again for us running late, but I appreciate both everybody for joining us, especially some of the subgroup members. And so we'll just go to the slides, actually. I'll run through these kind of quickly. Again, this first slide, I just wanted to highlight the guiding principles for the QBR program that we've said before, and especially the one where we're trying to move our measures and our targets to be as consistent as possible with the CMS VBP program. And the reason, well, let me go back. The original reason that we had a subgroup formed was to actually look at how we could provide ongoing quarterly reporting to hospitals so that they'd have a better sense of how they were doing in the QBR program, especially as we had increased, we're proposing increasing the amount of revenue at risk. As the subgroup was coming together, we actually ended up using the group to look a lot at some of the measurement and data issues that we were actually having for the measures that had been proposed, some of which applies both to fiscal year 16 and 17. And so I'll go through a little bit on that, and then we're still sort of tackling the quarterly reporting, and we'll talk about that as well, but briefly. So just as a reminder, these are the domain weights for the Maryland QBR versus the CMS VBP program. So safety measures are weighted at 35%. The clinical care measures are weighted at 20%, and that's 5% process and 15% outcome, which is mortality. And then the HCAPS is at 45%, and we are still do not have an efficiency measure in our program. And this is a little bit small, but this then lists the individual measures that are within each of those domains and which are included in the VBP versus the QBR program. So for the safety measures, we have PSI 90, Class C CAUTI, the SSI measures, and then those are all in the QBR program, and then also in the VBP are the C. difficile and the MRSA. And those will be measures we'll be looking for adding in future years. Under the process, or sorry, the outcome measures, the VBP program looks at 30-day mortality for certain conditions, and we just look at all-cause inpatient mortality. And then for process measures, the VBP program has 3 measures, but we only have one that we're able to have in our QBR program, and that is influenza immunizations. Again, the process measures are weighted at 5%, and it would be for that single measure. And then finally are the HCAPS measures. So the issues with the CLABSI data, we had said last year or in previous years that we would be moving to getting the data from the CMS or from Hospital Compare. And what we're finding is that the data that is posted on Hospital Compare is incomplete. So some hospitals don't have a measure, and it may be, it's for a variety of reasons we've found out, and I appreciate some of the hospitals looking into this. So for some, it's because they didn't have the appropriate Medicare ID listed, so the numbers weren't flowing through from the CDC to Hospital Compare. For others, it is that they have such a small sample size, or such a less than 1 expected cases, so the rate isn't being reported. We do, though, get data for all hospitals from MHCC, but what we found is the data is slightly different for some of the hospitals. The HSCRC recommendation, and I think we've gotten feedback from some of the subgroup members as well as some of the members through MHA, and what we are leaning towards is that since the majority of the hospitals have data on Hospital Compare, we're going to use it for fiscal year 16 and 17, and going forward. For the few hospitals that don't have data, we will either use the MHCC data or get data from them directly. And this will be a temporary kind of measure as we move forward, and assume that all hospitals will be reporting, will have their data on Hospital Compare unless the sample size is too low, in which case then that measure may not be counted for that hospital. I'm going to continue to CAUTI and SSI. The issues are similar there, but in that the data is incomplete on Hospital Compare. However, it's much more incomplete. And in fact, also, we only began collecting data in 2014, so we don't have 2013 data. Our recommendation is that we will use the MHCC data for these 2 measures for the coming year, again, with the long-term plan of moving to Hospital Compare. But we will set the benchmarks and thresholds using the fiscal year 2017 VBP measures, and that's going to be then based on calendar year 13. So the base period will be calendar year 14, but the thresholds and benchmarks will be based on the calendar year 13 national data. And we will then long-term go forward. I think that the sentiment was they'd rather include these measures in the safety domain rather than having the safety domain be made up of just Class C and PSI 90. I'll pause there and see if there are any thoughts or additional comments on that, or we're happy and we can move on. Again, for the process measures, and I apologize, I don't have a clinical background, but I've been told that we don't really do AMI 7A in the state, so we don't report that measure. We will, in the future, have PC01 included, and that's the it's the elective deliveries, premature elective deliveries, and then immunizations is the one that we will include. Again, we need to look. We haven't looked probably in the last 2 weeks, but at our last look, the base period data hadn't been out yet, but should be out very soon. Again, those are all the issues that are making it difficult for us to create that base year score to be used for scaling. But as I think we talked about earlier, we'll go ahead and model those base year scores as soon as we have the data, look at what the range and the median score would be, and then make a decision of whether it's significantly different than what we have now. So in terms of ongoing reporting, and so that hospitals can try to monitor the progress, we're still working out some of the details, but the plan would be that at least we will provide a calculation sheet to hospitals in Excel so that they can calculate their QBR score. We will for sure provide the mortality data as we've done historically on a quarterly basis, and we will also move to trying to report PSI 90. It may be for PSI 90 you don't get a quarterly score if you only have a quarter's worth of data, so we may have to do we think we have to do a rolling 12 months, so it won't exactly match, but it will get you close. And then it's our hope that for the safety measures and the HCAPs that hospitals can use internal data or the data that's available on Hospital Compare to populate that.
Allison, just a question. Is your thinking that HCAP is at a much higher percentage of weight as compared to CMS DBT because of our lagging behind?
Correct. So, we've had lower scores, plus our improvement hasn't been as great either, except for on the one measure on discharge planning, and so that's why we've emphasized HCAPs.
And is it your thinking that were we to catch up, that we would change that weighting?
I think we would definitely look at it. I think one of the big developments will also be having an efficiency measure, which will allow us to look at those weights again as well. Other thoughts, comments? I think a good deal of work has been done, and I appreciate everybody's input. If you do have any thoughts, especially any of the subgroup members that we've missed, we'll continue to work through how we'll do the ongoing monitoring, but thank you. I appreciate all the input.
Allison, it's Nicole Stallings. Just on behalf of the hospital folks on the subgroup, just want to say thank you for being so open and receptive to our concerns and addressing those in these recommendations.
Welcome. Okay. With that, I think we'll conclude this joint meeting that started late, but we appreciate everybody's attendance.
Thank you, everyone.
So just the next step, you expect the staff have a final recommendation out on Wednesday or a week in advance? Okay.